This is part two of the lecture on psychopharmacology, or drugs that affect mood, behavior, and those kinds of issues. So here we're going to explore some of the other drugs that we see used commonly as psychotropic medications in patients receiving physical therapy and physical rehabilitation. So in part one, we talked about the sleeping pills, the sedative hypnotics, the anti-anxiety drugs, and the antidepressants, including treatment of bipolar disorder. Now we're going to start with the antipsychotics and then segue from them into the treatment of dementia. So let's take a look now at the treatment of psychosis. Now, in terms of the drug treatment of psychosis, we understand that psychosis is a much more severe form of mental illness than conditions like depression or anxiety. People with depression are still often in touch with reality, but people with poorly controlled psychosis may not be. They may have visual, auditory hallucinations and literally see and hear things. They often have fragmented, incomplete thoughts. And the neurochemistry of psychosis has been fairly well defined. Psychosis seems to be due to an increased dopamine activity in certain pathways in the CNS, especially in the limbic system. So dopamine seems to be the problem, or the center of the problem, but other transmitters are certainly involved. Other neurotransmitters like 5-hydroxytryptamine or serotonin, glutamate, which is an excitatory amino acid, and acetylcholine are certainly also involved. But still, it's the increase in dopamine that seems to be the fundamental disruption in these CNS neurotransmitter system. So in terms of our antipsychotic drugs, all antipsychotics have to some extent, block central nervous system dopamine receptors. Specifically, we're often talking about a type of dopamine receptor called the D2. There are at least 5 subtypes of dopamine receptors labeled D1 through D5. So we tend to be talking about these D2 receptors that are important in things like the mesolimbic tract, the nigrostriatal pathways, again, important parts of the brain that are classically involved in controlling mood and behavior. So this slide is showing schematically how all antipsychotic drugs work. The presynaptic terminal on the left contains dopamine, the neurotransmitter dopamine. The yellow triangles are the antipsychotic drug. So we apply the right dose or supply the right dose to block some of these dopamine receptors, not all of them. We don't want to shut down this pathway, but block enough so that when dopamine is released, it does not overstimulate the postsynaptic neuron. So clearly we're trying to normalize dopamine activity in these pathways. And again, that's how, if antipsychotic drugs are going to have a therapeutic effect, they all do this to some extent. So what are some of the common antipsychotics? There are many, and they used to be classified according to their chemistry. Now we simplify the issue by classifying these drugs as either traditional antipsychotics or what we call the newer atypical antipsychotics. And atypical is not a detrimental thing. It simply means the drugs are not typical in terms of their side effects. And these atypical or newer agents may be preferred because they do have fewer, milder side effects in most patients. So we want to take a look at some common examples of these drugs. In terms of traditional drugs, we see drugs like Thorazine, Haldol, very, very common, very widely used. Compazine, which is often used to treat nausea too. So we may see it used for both treatment of psychosis as well as treatment of severe nausea. And many others. There's several dozen of these traditional drugs that are still possibly being used clinically. But what we've seen is this newer or atypical group really kind of go to the head of the class. Drugs like Clozaril, Risperdal, which are really the first two to enter the market in this group. But other drugs like Zyprexa, Seroquel, again, considered atypical. So we want to take a little closer look at how these drugs may differ from the more traditional drugs. In terms of atypical antipsychotics, no question they still block the dopamine type 2 receptor to some extent, but they tend to be weaker blockers than the more traditional agents like Haldol. In addition, they also strongly inhibit or block specific serotonin receptors. These are the so-called 5-hydroxytryptamine type 2 receptors. And some experts think this is why they're more beneficial. Other people say, well, this is true, but it's really the fact that they're not so strongly blocking the D2 receptors that gives us the benefits of fewer side effects. Regardless, many patients do just as well on these drugs in terms of treating the psychosis with less incidence of severe side effects we're going to talk about later. So are they better at treating psychosis? Not necessarily, but if they do have fewer and less serious side effects, they may simply be better tolerated. Patients will be more adherent to drug therapy. Some recent evidence has suggested that at higher doses, the difference in the side effects may also start to be lost to some extent. But still, at therapeutic doses or at lower doses, they tend to definitely be better tolerated and therefore more useful in a lot of people with. So what are the adverse effects? Traditional agents, they cause a lot of orthostatic response. Patients stand up, their blood pressure falls. These drugs are more sedative, and they tend to cause more of this anticholinergic package where you're affecting acetylcholine throughout the body. So you get problems with increased heart rate, decreased GI movements, bladder retention or urinary retention in the bladder, dry throat, and so forth. All these are due to the fact that the acetylcholine is involved in all of these other systems. The newer agents tend to produce less of these traditional responses, sedation and so forth, but some patients experience pretty profound weight gains, increased blood lipids, decreased glucose sensitivity or insulin sensitivity, almost mimicking type 2 diabetes. So a lot of patients started on these drugs and did well in terms of treatment of psychosis, but had to go off the drugs because these side effects, including the weight gain, can be pretty severe. But the primary concern of all antipsychotics, probably the most important for us to realize, is that these drugs can produce extrapyramidal or motor side effects. They're often called extrapyramidal side effects because the symptoms will mimic lesions in the extrapyramidal motor pathways. So as soon as we start talking about motor problems that are drug-induced, we have to really pay attention to this as clinicians. So let's take a much closer look at these possible. So what are some of the common problems? Well, first, there's a problem called tardive dyskinesia. And what it usually is typified by is oral facial movements, grinding movements of the jaw, protruding tongue or movements of the tongue, smacking of the lips. Granted, it can also affect the extremities and the trunk, but really classically it's facial movements, and especially oral facial movements, grimacing of the face. So tardive dyskinesia is a real notorious motor problem of these drugs. Pseudoparkinsonism totally makes sense because in Parkinson disease, classic Parkinson disease, we often see, we associate this with a decrease in dopamine activity. What we're seeing now is we're trying to decrease activity of dopamine in a different part of the brain. But if some of the drug finds its way to the basal ganglia, we're going to have symptoms of Parkinson disease. Now, if the patient does not actually have Parkinson disease and you take the drug away, the symptoms should disappear. That's why it's pseudoparkinsonism. But you have to also be aware that there's often a comorbidity or possible comorbidity where a patient could have real Parkinson disease and psychosis, which gets very hard to treat. But anyway, that's another classic motor side effect. And the symptoms are very similar to Parkinsonism. Rigidity, bradykinesia, fine tremor, so forth. Another one is akathisia. This is severe restlessness. Your patients literally cannot sit or stand still. They'll often march in place or follow you all around your clinic. And again, if they're sitting down, they'll cross and uncross their legs repeatedly. If you see it, it'll be very obvious. And various other dystonias and dyskinesias. Again, often of the extremities, chorioathetoid, almost chorioathetoid-like movements. So we have these potential side effects because dopamine is so important in controlling motor function in other areas of the brain. Of these problems, the most feared is the first one, tardive dyskinesia. And that's because it may be permanent. It's a drug-induced side effect that can be permanent, that may never go away. And even if it's recognized early, it may take several months to disappear. So let's take a little closer look at what. First of all, it's pretty common. About 1 out of 4 patients on long-term traditional antipsychotics exhibit symptoms of tardive dyskinesia. So that's pretty high, 25%. The cause is not clear, but some experts believe it's almost like a denervation supersensitivity. What this means is if a drug blocks a receptor, it's almost like denervating the excitatory input to that receptor, and the postsynaptic neuron will simply increase more receptor activity, actually make more receptors. And this is true for any kind of a blocker, a drug that blocks receptors. So this may explain some of the symptoms of tardive dyskinesia. The risk factors are older patients, advanced age. There's certainly some genetic issues involved too. People that do have affective mood disorders like depression, people with diabetes mellitus, who have a history of alcohol abuse, and who've been on the drug for more than 6 months continuously. The best treatment is early recognition and a change in the type or dose of the drug. Some drugs are more prone to this. Obviously, some of the more traditional drugs are more problematic in terms of causing tardive dyskinesia, but certainly dose could also be considered too. So we're really watching for these. As physical therapists, we're often in the very best position to start to see these symptoms early, both tardive dyskinesia and all the other motor problems that we just saw. We are the motor experts, so we simply have to be more aware that these problems could occur.
Press pause and read this slide before proceeding to the next one for the answer.
Another serious problem that can happen with antipsychotics is called neuroleptic malignant syndrome. These drugs used to be called neuroleptics, so that's what this really is referring to, and it can occur with all antipsychotics. The symptoms are catatonia, stupor, unresponsiveness, also rigidity, tremors, fever, and this can get very serious very fast. Especially in patients that are taking a high dose, who are agitated, or who have some impaired mental function, like some mental retardation. Not sure why, but those are the risk factors. And the reason it's serious is it can be fatal, that the catatonia and so forth can progress to coma and even death. So we need to detect it early and stop the drug. So once again, we're watching our patients. We're monitoring their musculoskeletal, neuromusculoskeletal function and looking, is there any problem with tremors? Is there any problem with rigidity? And if so, let the medical practitioners know right away, because we have to, this as you see, it can be serious and get out of control really fast. So in terms of our major concerns, this is another situation where the drug can dramatically improve the patient's ability to engage in physical therapy. A patient that's very withdrawn or very agitated may be much more, again, engageable. But if the drug causes a lot of sedation, we're not going to get anywhere because the patient's going to be so sleepy all the time. So once again, we're trying to find the correct drug and the correct dose to get the benefits without the excessive sedation or other side effects. We want to be alert for orthostatic hypotension. A lot of times our patients with psychosis will not tell you they're getting dizzy. So watch their coloring, watch them carefully. If possible, maintain a conversation with the patient when they're on their feet. And if they stop responding, they may be getting into trouble. But probably the most important is the extrapyramidal side effects and our ability to recognize these side effects early. As we saw, especially tardive dyskinesia, because the best treatment still is to get off the drug as fast as possible, or at least to change drug therapy as fast as possible. Now I want to leave psychosis and talk specifically about dementia, and I'm going to talk about dementia of the Alzheimer type. Now granted, there are many other types of dementia and many other causes, including drug-induced dementia. But we want to talk about irreversible dementia of the Alzheimer type, which involves profound degeneration and neuronal changes throughout the brain. In terms of the gross function of the brain, you can actually see that the brain is shrinking. And on a neurochemical basis, we see that as a person progresses from normal to mild cognitive impairment to Alzheimer's disease, we see simply a loss of brain function, a loss of neuronal activity. And on a microscopic level, we can talk about the plaque formation and the neurofibrillary tangles and the buildup of proteins, amyloid proteins in the neurons. But my point is that this is not a minor change. This is a pretty profound change throughout the entire brain. So what are our goals with medications, at least right now, with what we have right now to treat Alzheimer type dementia? Do we have drugs that actually improve cognitive function and intellectual ability and memory? Let's look at that first. And then, do we have other drugs that might actually, or might at least help improve or modify behavior in a patient that is agitated or depressed? But let's talk about the actual cognitive, intellectual, memory type drugs first. So the question arises, do we have drugs right now that may help improve cognitive function, intellectual function, memory in people with Alzheimer's disease? And what we saw a few minutes ago is that the neuronal degeneration throughout the brain is profound, and all the neurons are suffering to some extent. But it seems to be these acetylcholine neurons in the higher parts of the brain, the higher parts of the cortex, that are causing the most profound changes, that these are so important in maintaining memory and so forth. So these neurons are suffering the most, or at least the effects we see are due a lot to the loss of these important acetylcholine producing neurons. So we're going to talk about ways to try to stimulate acetylcholine function in this part of the brain. And we have several drugs that act like acetylcholine, but they either have very short half-lives or, more likely, produce a lot of side effects because acetylcholine is so common throughout the body. And if you're not affecting just that part of the brain, you're going to also affect the heart, the lungs, the GI tract, and so forth. So what we've tried to do is develop cholinergic stimulants that are somewhat selective for this area of the brain. And rather than directly stimulating cholinergic receptors, we've tried to do a bit of an end run and develop drugs that will prolong the effect of acetylcholine that's still present. And that's why they're called indirect cholinergic stimulants. So let's take a closer look at that in the next couple of slides here. So we're talking about indirect cholinergic stimulants. In other words, don't directly stimulate the acetylcholine receptor, but rather inhibit the enzyme that breaks down acetylcholine. And that enzyme is called the cholinesterase, or the acetylcholinesterase. So if you do this, if you inhibit acetylcholine breakdown, you'll get more mileage, or you'll get prolonged activity and effects of any acetylcholine that is present. And that's been our major strategy to treat Alzheimer-type dementia. Use drugs that inhibit the enzyme that breaks down acetylcholine in the higher parts of the brain. And that's shown schematically in the next slide. So here we see a synapse, and let's say we're in the cortex, higher parts of the cortex. Presynaptic terminal contains acetylcholine. Postsynaptic neuron on the right is waiting for that neurotransmitter, but now you see this big yellow enzyme, the cholinesterase, waiting to destroy the transmitter after it's been released. And in normal function, sure, the acetylcholine is released, stimulates the postsynaptic receptor, but is almost instantly destroyed by this enzyme, the acetylcholinesterase. So the anti-dementia meds we're about to meet, they inhibit this enzyme. So now, when acetylcholine is released, it remains active longer. So that's what we mean by prolonging the effects, or what I think of as getting more mileage out of this neurotransmitter. And if we can do that, we may get better effects and better improvement of intellect, cognition, and memory. So what do we have right now? Well, drugs like Aricept, donepezil or Aricept, which is probably the most famous of this group. There are a couple of others like Razidine, Exelon, Tacrin or Cognex was actually the first one developed. And there may be others. Once again, these are not inhibiting the acetylcholinesterase to any large extent elsewhere in the body, and they were developed for this reason, because they do have some selectivity for the acetylcholinesterase in the higher parts of the brain. But at least we've got these four now. In fact, Exelon, I believe, is still available by a patch, which might be helpful for some people to get a more prolonged effect. And as I said, I'm not sure, but we may see others in this group. So, like I said, these drugs were developed specifically to treat this problem, to improve cognition, behavioral function, memory in people with Alzheimer's disease. And they tend to be effective, especially in the early to moderate stages of this condition. And they will help patients retain more cognitive and intellectual and memory function. But in most patients, especially patients that are progressing fairly steadily or even rapidly with Alzheimer's disease, there becomes a point where you question whether the drugs are still having any beneficial effect. And that's probably true because of the way they work. Remember, they prolong the effects of acetylcholine after it's released. If the neuron releasing the acetylcholine has degenerated to the point where it no longer produces that neurotransmitter, these drugs cannot have any beneficial effect. So this is a well-known fact that in most people that have progressive Alzheimer's disease, which is most people with Alzheimer's disease, there gets a point where you really question whether the drugs are useful any longer. But still, benefits in the earlier stages can help the patient remain living at home, caring for himself or herself, or working with a caregiver or spouse. So these have been helpful, at least to some extent, in many patients.
Press pause and read this slide before proceeding to the next one for the answer.
Now, a newer option is this drug called Namenda, Memantine or Namenda. It works very differently than the drugs we just saw. It blocks a receptor called the N-methyl diaspartate glutamate receptor in the brain. Very important receptor. It's stimulated by excitatory amino acids like glutamate and aspartate. And it has an important function in a lot of activities throughout the brain. What we're seeing in people with Alzheimer's disease is that glutamate activity, or glutamate as an excitatory transmitter, is important in memory and learning. Too little is going to be harmful, but too much might be harmful too. And that is what we think is going on here. As there begins to be neuronal destruction, there may be overstimulation by these excitatory amino acids, which may actually precipitate the onset and the advancement of the damage in Alzheimer's disease. So again, a very different drug, but this has been a nice addition because now we can come at the problem from a slightly different angle than we would with drugs like Aricept and the other acetylcholinesterase inhibitors. So, we believe glutamate activity is disrupted in Alzheimer's disease, may be too active, and this drug tends to normalize that activity. And as I said, it does provide another strategy to slow the progression of Alzheimer's disease, to sustain memory and intellect. And it may be useful combined with, because they work differently, can be useful combined with one of the more traditional drugs, like Aricept. We'll hopefully stay tuned to see if maybe using this drug earlier in the course of the disease may actually slow the progression, or if we have other drugs that are similar to this that may be helpful as well. But for now, at least we have this drug. So what we saw are drugs that try to at least reduce the fundamental problem in people with Alzheimer's disease. The question then is, what else do we have? Well, all the drugs we've talked about in the other parts of this course dealing with psychotropic issues. The antidepressants, for example, anti-anxiety drugs, and the antipsychotics. And in the past, antipsychotics were arguably overused for this reason, that if a patient became agitated in some way, they would give a strong dose of a traditional antipsychotic to act almost like a chemical constraint or restraint. There's been efforts now to use all of these drugs a little more effectively. And we'll see that in the next slide. So in terms of using these, for lack of a better term, drugs to modify behavior, the government stepped in to institute regulations to curb the indiscriminate use of the antipsychotics. You can't just give an antipsychotic whenever a patient has a behavior that is considered unacceptable. Yes, antipsychotics can be useful in some patients who are agitated, but again, don't just use them indiscriminately to stop activities like wandering and so forth. And the idea being to emphasize more the use of what we call symptom-specific medications. What that means is an antipsychotic will not be as helpful if a person has symptoms of depression, or an antidepressant may not be as helpful if a person has more classic anxiety. So the idea is to be careful about analyzing the symptoms and using the best drug out of this group, maybe to treat those symptoms. And likewise, there's been much more emphasis on using non-pharmacological interventions. And there are many examples of this, especially where clinicians, physical therapists included, have become very creative in what they do in helping make the patient feel more oriented to their environment. And of course, we see many people with Alzheimer's disease feeling very confused and disoriented. So to surround the patient with things they can identify with, and to work within that patient's specific symptoms or characteristics to calm the patient. And people have been, as I said, very creative in this aspect. So we'll have to stay tuned. Those are what we have right now to treat Alzheimer's disease. Clearly, this is an important area for drug research, and hopefully we'll see other advancements in the near future. So that's it in terms of our discussion of treating psychotropic issues, both in part 1 of this lecture as well as part 2. I started out by saying these are very common disorders, and we tend to see them used a lot. And used effectively, they can often be very helpful in helping us engage and involve our patients in what we're trying to do in rehabilitation.